Good day everyone, and welcome to this educational series titled Traumatic Brain Injury Explained, a step-by-step clinical guide. In this multi-part lecture, we'll take a comprehensive journey through the clinical aspect of traumatic brain injury, starting from the very basics and progressing to advanced diagnosis and management strategy. Today, in part 1, we lay the foundation by answering a fundamental question: what is traumatic brain injury? We'll define traumatic brain injury, explore its causes, mechanisms, and classifications, and understand why it remains one of the most important and complex conditions in emergency medicine and neurosurgery. Let's begin with the formal definition of traumatic brain injury as provided by the United States Department of Veteran Affairs and Department of Defense Clinical Practice Guideline for Management of Concussion and Mild Traumatic Brain Injury. Traumatic brain injury is defined as a traumatically induced structural injury or physiological disruption of brain function caused by external mechanical force. Clinically, this diagnosis is supported by the new onset or worsening of one or more key features following head trauma, and these include loss of consciousness, post-traumatic amnesia, altered mental status, vocal neurological deficits, and imaging evidence such as intracranial hemorrhages, contusions, skull fractures, or diffuse axonal injury may help to confirm this diagnosis. This broad clinical spectrum reflects the complexity of traumatic brain injury and reinforces the importance of recognizing even subtle signs early. Traumatic brain injury doesn't just affect the brain structurally, it disrupts both neural and vascular systems, leading to significant and often lasting neurological dysfunction. Its clinical spectrum ranges widely from mild concussion to deep coma or even death, making early recognition and tailored management crucial. Because the mechanisms are diverse and complex, diagnosis and treatment are not always straightforward. Every case may present differently depending on the location, force, and nature of injury. Importantly, the impact extends beyond the acute phase. Over half of traumatic brain injury survivors experience long-term psychological, cognitive, and functional challenges. These often interfere with their ability to live independently and significantly reduce quality of life. Traumatic brain injury is a major global health issue, affecting an estimated 69 to 104 million people annually. It's not just a clinical problem, it's a leading cause of death and disability, and it poses a global economic burden of nearly $400 billion per year. The highest risk age group include young adults, 15 to 45 years, primarily affected by road traffic accidents, violence, and workplace injuries. Elderly, due to falls, frailty, and balance issues. Children under 5, who are prone to accidental falls and trauma. There is a clear gender disparity as well. Males are up to 4 to 8 times more affected than females, largely due to greater exposure to high-risk activity. Lastly, traumatic brain injury patterns vary by geographic and income level. In low and middle income countries, road traffic injuries are the leading cause. In high income countries, falls, especially in the elderly, are the most common. Understanding these patterns helps in planning preventive strategies and targeted interventions. The causes of traumatic brain injury are multifactorial and vary by age, region, socioeconomic context, and individual behaviors. Recognizing these causes is crucial not only for clinical care but also for developing effective prevention strategies, allocating trauma care resources, and guiding public health interventions. Road traffic accidents are the leading global cause, especially in low and income countries, involving cars, motorcycles, and pedestrians. These typically result in high energy trauma. Falls are predominant in children and the elderly, often from furniture, stairs, or scaffolding, and are a major cause of traumatic brain injury in high-income countries. Occupational injuries seen in construction, mining, and factories are often due to falling objects or machinery and are largely preventable with proper safety practices. Violence and assaults, including gunshots and blunt traumas, are common in street violence and domestic abuse. Child abuse must always raise suspicion, especially with non-accidental trauma. Other causes include sports and recreational, especially contact sports and cycling, blast injuries in military and industrial settings, substance-related trauma, alcohol or drug-induced injuries, self-inflicted injuries, and psychiatric conditions, including suicide attempts. Understanding this wide spectrum of causes helps clinicians tailor evaluation, treatment, and prevention efforts appropriately. Understanding the mechanisms of external force is critical in evaluating and managing traumatic brain injury. Each mechanism causes distinct injury patterns with different clinical and radiological presentations. Direct impact is the most visible and common mechanism. It occurs when the head hits an object or vice versa, often seen in falls, assaults, and contact sports. It leads to co- and counter-co injuries due to brain rebound. Common findings: scalp lacerations, skull fractures, and cortical contusions, especially in the frontal and temporal lobes. Acceleration-deceleration injury occurs when the head moves rapidly, then stops, like in car crashes or whiplash injuries. It causes the brain to shift within the skull, leading to diffuse axonal injury, cerebral edema, or contusions, often without external signs. Shearing forces most affect the gray-white matter junction. Penetrating head injury are complex and often fatal injuries involving dural breach, and communication with the outside environment. Missile injuries causes high energy trauma and tissue necrosis. Non-missile injuries, example of knife, occurs in civilian violence and may have better prognosis. There are high risk of infection and vascular injury. Urgent cranial CT scan or cranial CT angiography imaging and antibiotics are crucial in the management of this patient with such injuries. Blast injuries are common in military or industrial settings. They result from pressure waves and fragments. Severity depends on proximity, explosive types, and environment. 4 injury phases usually occur. A primary injury, which results from blast wave, affects air-filled organs and brain. Secondary injuries arising from flying debris causes penetrating trauma. Tertiary injuries, the patient is thrown, hence sustaining blunt trauma and diffuse axonal injury. Quaternary injury result from burns, toxins, and psychological impacts like post-traumatic stress disorder. Recognizing these mechanisms enables clinicians to predict complications, guide imaging, and tailor acute care, ultimately improving outcome in traumatic brain injury. Why classify traumatic brain injury? Classification is more than labeling. It's essential for clear communication, standardized care, and effective decision making. By using consistent framework like the Glasgow Coma Scale, we ensure that clinicians, researchers, and health systems speak the same language when discussing injury severity and prognosis following head trauma. Classification helps to quickly convey severity. It guides treatment decisions. It predicts outcome. It supports research by standardizing inclusion criteria and enabling data comparison across institutions and regions. It optimizes resource planning from trauma centers to rehabilitation services. Common classification domains include by severity, using the Glasgow Coma Scale, by anatomical type, such as contusion, hematomas, which could be extradural or acute subdural hematoma, diffuse axonal injury, by mechanisms. And why the GCS introduced in 1974 by Tisdale and Janet remain the cornerstone, we must be mindful of its limitation, such as influence by sedation or intubation, and variability between assessors. So classifying traumatic brain injury is not just academic, it's foundational to good clinical care and system level planning. We'll look at the anatomical classifications. We'll look at each of these conditions briefly. Looking at cerebral contusion. This is essentially a brain bruise caused by direct impact or sudden deceleration leading to microvascular damage. This results in bleeding into the brain parenchyma, often accompanied by swelling and edema. These injuries are commonly found in the frontal and temporal lobes, especially in counter-co patterns, when the brain strikes both the site of impact and the opposite side due to rebound. One important complication is hemorrhagic progression of contusion. Here, the initial bleed may expand or new remote hemorrhages may develop over several hours, posing a risk of delayed clinical deterioration. Clinically, this means we need to perform serial neuroimaging, monitor closely for worsening symptoms, and be ready to escalate care, including potential surgical intervention. In summary, contusions are dynamic lesions that require vigilant monitoring and proactive management. Acute epidural hematoma is a life-threatening type of extra-axial bleed that occurs between the inner surface of the skull and the outer dura. Inner surface of the skull and the outer dura. It accounts for about 10% of all traumatic brain injury and is considered a neurological emergencies. The bleed is usually arterial in origin, most often from the middle meningeal artery, though venous sources like torn dural sinuses contribute in around 10% of cases. A key anatomical point is that epidural hematoma are limited by cranial sutures because the dura is tightly adhered to those points, so the hematoma does not cross suture lines. The classic clinical presentation include an initial loss of consciousness, a lucid interval, followed by rapid neurological decline. On neuroimaging, you see a biconvex hyperdense lesion, which is highly characteristic. Surgical evacuation via craniotomy is the treatment of choice in symptomatic patients, especially if the hematoma is over 30 mils. There is a midline shift greater than 5 mm, or the patient shows a neurological deterioration. Prompt recognition and intervention are critical to prevent fatal brain herniation. Acute brain injury, acute subdural hematoma is a serious life-threatening extra-axial bleed that occurs between the dura and the arachnoid matter, usually due to rupture or breaching veins, often from trauma or acceleration-deceleration injury. It is a neurological emergency due to the potential for rapid increase in intracranial pressure, midline shift, and herniation. On non-contrast CT, acute subdural hematoma appears as a crescent-shaped hyperdense lesion that may extend across suture lines. Pathologically, it acts as a space-occupying lesion that raises intracranial pressure, causes brain shift and herniation, and may also lead to cerebral ischemia and delayed hematoma expansion. Surgical evacuation is indicated if clot thickness is greater than 10 mm or midline shift greater than 5 mm. Glasgow Coma scale score less than 9 with any hematoma. Observation may be appropriate if the hematoma is less than 10 mm with midline shift, or when midline shift is less than 5 mm, or when patient is neurologically stable. Prognosis is usually influenced by the initial Glasgow Coma scale score, hematoma size, time to surgery, patient age, and comorbidities. Early recognition and timely neurosurgical interventions are critical. Intracranial hemorrhage is bleeding into the brain parenchyma, typically due to traumatic rupture of cerebral vessels. It occurs in about 8 to 10% of traumatic brain injury cases. Hematoma expansion, seen up to 59%, usually occurs within the first few hours and can cause delayed neurological deterioration. Risk factors for expansion include older age, severe trauma, coagulation disorders, and multiple brain injury lesions. Management depends on severity. Surgical evacuation is indicated for large bleeds greater than 30 to 40 cm3, significant midline shift greater than 5 mm, or worsening neurological status. Early recognition and imaging are key for timely intervention. Diffuse axonal injury is a severe form of traumatic brain injury caused by rapid acceleration, deceleration, or rotational forces that leads to widespread shearing and stretching of axons. Despite its name, diffuse axonal injury affects specific regions like the white-gray matter junction, corpus callosum, brainstem, and cerebellum. It is often associated with coma and poor prognosis. Primary injury involves axonal disruption and formation of retraction bulbs, while secondary injury is driven by calcium-mediated protease activation and mitochondrial dysfunction. Diffuse axonal injury should be suspected in patients with low Glasgow Coma scale, but normal cranial CT scan findings. Cranial CT scan may show small hemorrhages. However, MRI, especially diffusion tractography imaging, is more sensitive for detecting axonal imaging. For axonal damage, emerging biomarkers such as neurofilament, tau proteins, and APP may support diagnosis. Skull fractures can be classified into three main types. Linear fractures are the most common and usually benign. Depressed fractures involve inward displacement of bone, potentially compressing brain tissue. Basilar fractures affect the skull base and present with characteristic signs like raccoon eyes, Bartle signs, and CSF leak from the nose or ears. Complications include cranial nerve injury and intracranial hematomas, requiring careful assessment and monitoring. Traumatic brain injury is a major public health concern, especially among young adults, as it leads to significant mortality, disability, and long-term healthcare costs. Patients often suffer long-lasting cognitive, emotional, and environmental impairment that hinder quality of life and reintegration. Timely management is crucial to prevent secondary injury, herniation, and death. Highlighting the importance of intervention during the golden hour. Effective outcome depends on system-level readiness and well-coordinated trauma care. Today, we have covered the fundamentals of traumatic brain injury, its types, mechanisms, and clinical relevance. Early recognition and timely intervention are key to improving outcome. In the next episode, we'll explore the pathophysiological phases of traumatic brain injury, shedding light on how the brain responds from injury onset through recovery. These are my selected references. Thank you for watching.